So let's begin our program. And I'm extremely sorry, dear my doctors, for the technical glitch. And now I think it's set. So I'm Dr. Sepuri Mohan, a senior endocrinologist. I have my own center, Sepuri Diabetes and Endocrine Center, Kurnool. So today we are going to talk about the the combination of the SGLT2 inhibitor and a DPP4 inhibitor actually. So the title being the Dapagliflozin Circle of Protection, and today's topic is the SGLT2 inhibitors plus DPP4 inhibitors in the management of type 2 diabetes. And this is my disclaimer. And today's topic is being divided into the diabetes epidemiology and the combination therapy in the management of type 2 diabetes mellitus, the SGLT2 inhibitors plus the DPP4 inhibitors combination, and today's topic being the Dapagliflozin plus Sitagliptin combination, and guidance for initiation of SGLT2 inhibitors plus DPP4 inhibitors, the combination in the management of type 2 diabetes mellitus, and finally the take home message. And before I start my topic, see, you're all aware that the two popular molecules, the two subsets to different classes of molecules, you are already well aware of. The one being the DPP4 inhibitor class, and second being the SGLT2 inhibitor class. And out of which, now we are going to talk about the Dapagliflozin 10 milligram plus the Sitagliptin 100 milligram. You are all aware that these two molecules have become off patented, like the Sitagliptin is off patented and now it is available in the generic form. And since the AstraZeneca people have lost the case in the Supreme Court of India, now the generic versions are available in our country at a very affordable price. That is the reason we are able to pass on the benefit of this particular either the Dapagliflozin or the Sitagliptin, or the put together the combination of Dapagliflozin and the Sitagliptin to the patient population. Otherwise, it would have been impossible for us to pass on the benefit to each and every needy patient. And now it's possible because of that. The Janica people losing the case, and the Sitagliptin has become off patent. And now we start with the epidemiology, that is the diabetes mellitus in India. And 2021, actually, this what I am going to preach, teach, and practice is only evidence-based medicine. Only evidence-based medicine. Nothing other than evidence-based medicine. So this is taken from the 10th Atlas of Diabetes from International Diabetes Federation, which says that the 2021 China is heading the world with the highest number of diabetic population from 2012 onwards. So as on today, like 2021, the patient suffering from diabetes is 140.9 millions in China, and the second place, India, with 74.2 million cases of diabetes. Until 2012, the World Diabetes, the World Health Organization has accredited India as the diabetes capital city of the world. But very fortunately, China has surpassed India. And on the right hand side, you can see the projections by 2045. Again, the rank is same. China in the top place, India in the second place. But the difference is the number of people with diabetes That is, from 141 million, the China will be like heading the world with the maximum patients suffering from diabetes mellitus with 174 million, whereas from 74 million, India in the second place to a tune of 125 million, which is almost alarming actually. It is abnormal proportions. So the inference is India ranks number two for the number of people with diabetes mellitus, and the same rank is projected by 2045, and age adjusted prevalence of diabetes is 9.6% projected to increase by 10.4 by 2030, and India accounts for 1 in 7 of all adults living with diabetes worldwide. The real world evidence of glycemic control among patients with type 2 diabetes mellitus in India. This is taken from the TIDE study. On the left hand side, you can see the bar diagrams, and the black bar is the male, and the white bar is the female. So first one is the y-axis is the percentage, and the x-axis is the A1C in percentage. First is like less than 7, and the second bar is 7 to 8%, and third is more than 8 to 10%, and the last bar is like more than 10% of HbA1c. You can very clearly see how many people are maintaining the target as set by the American Diabetes Association, that is an A1C of less than 7. You can see that less than one quarter is maintaining an A1C, and more than three-fourths of the diabetic population in our country are not to the target. The retrospective analysis of the 55,639 patients suffering from type 2 diabetes mellitus, and the inference is the 76.6% of the patients, they had uncontrolled HbA1c of around or more than 7%, which is very very alarming, at the same time very pathetic also. And now you can see this the busy slide. This shows the diabetes as a cardiovascular risk factor. We all know that see, diabetes is nothing but the vasculopathy. So either it is the microvasculopathy or the macrovasculopathy, and now on the left hand side you can see the macrovascular complications of diabetes, the coronary heart disease, the heart failure, the peripheral artery disease, and the stroke. And on the left hand side, you can see the microvascular complications, nephropathy, the retinopathy, the neuropathy, and nephropathy. And for your kind information, from 2016, the American Diabetes Association has abolished the word nephropathy and has incorporated the new term, the diabetic kidney disease. It is only with an intention that all the healthcare professionals and all the healthcare providers must be very familiar with the word. Instead of nephropathy, you say diabetic kidney disease. It's a very simple term. So that is the reason why they have said it is diabetic kidney disease. So moving on to the next slide, which shows the importance of the multifaceted. Hello, please unmute yourself, please. Hello. So now this slide shows the importance of multifaceted management of the cardiovascular risk factors, and you can see on the top the physical inactivity that leads to overweight and obesity, and that leads to cardiovascular risk straight away. And on the other hand, this leads to
సార్ ఈ లెఫ్ట్ చెప్తున్నాను సార్ పర్లేదు.
Not able to hear?
ఇప్పుడు క్యాప్చర్ ఇక్కడ నుంచి తీసుకుంటాను.
Oh, technical team. Am I audible now? Hello, can someone answer? Am I audible?
ఇప్పుడే కట్ అయిందంట సార్.
Hello?
Yes, sir. Now you can carry on.
Yeah, please. Yeah. See, coming to the importance of the multifaceted management of cardiovascular risk factors, and first thing is physical inactivity, which leads to overweight or obesity, that straight away leads to the cardiovascular risk. And the two key players, the genetics and the age, along with the physical inactivity, that leads to this particular insulin resistance, which in turn leads to not able to hear. Hey, what is technical team doing?
So sound is coming from here, sir.
What is the technical team doing in the back end, please?
Team, is it clear? Now it's clear. My mobile is also here.
Yeah, now I can hear your voice, sir.
Now, somebody is saying constantly, I am not able to hear.
Sir, that was earlier actually, not now.
Am I audible now?
Yes, sir. Yes. If you are not audible, I'll interrupt.
Yeah, please you interrupt and tell me. Okay.
Yes, sure, sure.
So the insulin resistance leads to prediabetes and diabetes and the metabolic syndrome, which are the causes, risk factors for the cardiovascular risk. On the down you find smoking, along with that alcohol, and on the right hand side you take the abnormal lipid metabolism that leads to cardiovascular risk, and age, race, sex and family history, they contribute to cardiovascular risk factor. And the last one is hypertension. So the importance of this particular slide and the take home message is, all the time you have to classify the risk factors as modifiable risk factors and the unmodifiable risk factors. See, all are modifiable risk factors except the age, race, sex and the family history. They are never modifiable. So the unmodifiable risk factors, they play a vital role in causing the cardiovascular risk. So for everything there is a solution. All the modifiable risk factors have got a solution, like physical inactivity, overweight and obesity. You can lose weight by becoming very active and eat better, and as far as the prediabetes and diabetes and the metabolic syndrome and the insulin resistance can be reduced by maintaining absolute glycemia. And the smoking and alcohol, you can just prevent these two risk factors by cessation of smoking and alcohol. And abnormal lipid metabolism can be controlled very meticulously with statins and etc., diet and exercise. And hypertension can be very much controlled with DASH diet and the other modalities and the drugs. But the only one, the unmodifiable, the set of risk factor, age, race, sex, family history, cannot be handled by anyone. So you have to be very meticulous as far as age, race, sex and family history are concerned. And this slide shows the effect of factorial intervention in type 2 diabetes mellitus. This is taken from Steno 2 study. The left hand side you can see two graphs actually, and the y-axis is the cumulative incidence of any cardiovascular event, and the x-axis is the years of follow-up. The red one is the conventional therapy and the blue one is the intensive therapy. And you can find that there is the curves getting separated from the beginning. When the two are compared, the conventional therapy and the intensive therapy, intensive therapy has got a better results when compared to the conventional therapy, and where the p-value is 0.001, that means it is statistically very significant. And the inference is the intensive control of the several cardiovascular risk factors, including glycosylated hemoglobin and the blood pressure and the lipid profile in patients with type 2 diabetes mellitus, and albuminuria reduced composite cardiovascular events by 53% during a follow-up of 7.8 years. This is from the Steno 2 study. The combination therapy versus stepwise approach in type 2 diabetes management. Let us see on the left hand side the stepwise therapy, what are the potential advantages. On the right hand side, the combination therapy, what are the potential advantages. The stepwise therapy has got like very easier to access efficacy bar side effects of the new drug added, that is to calculate the risk to benefit ratio, and easier individualization of the therapy and the cost. And second is the combination therapy. The use of the combination drugs aimed at targeting multiple pathogenic mechanisms simultaneously, preferably by complementary mechanism of action, that is called the synergistic mechanism of action, and the earlier and the greater achievement of glycemic goals, and the potential delay of disease progression and preservation of beta cell function, and reduction in the clinical inertia. Clinical inertia may be the clinician's inertia or the physician's inertia or the patient's inertia. And now the funda is treatment of diabetes has changed. Hit early, hit hard. That's what. Treat early and treat right. And the resume simplification and the medication adherence, the FDC, that is the fixed dose combinations versus the loose dose combination therapy for the management of type 2 diabetes mellitus. You can clearly see the Kaplan-Meier curves displaying the proportion of individuals without a discontinuation of treatment with the FDC and the LDC, that is loose dose combination cohort. And here the first one is, the blue line is the fixed dose combination, and the red dotted line is loose dose combination. So you can clearly see the difference between the two graphs. The inference is the fixed dose combinations can lead to a significant improvement in the adherence of pharmacological therapy of type 2 diabetes when compared to loose dose combination. That's going to the FDC has got the greatest advantage of minimizing the polypharmacy and improving the patient adherence actually. And this slide shows, this is a busy slide which shows the complementary mechanism of action between the SGLT2 inhibitors and the DPP4 inhibitors. So the mechanism of action of the SGLT2 inhibitors. See, first it increases the urinary glucose excretion and the activity of NHE3, and glucotoxicity is reduced, and plasma volume and the glomerular hyperfiltration is also reduced, and sensitivity of the beta cells is increased, thereby reducing the insulin resistance and reducing the sympathetic tone and reducing the activity of the NHE1, and improving the hematocrit and the hemoglobin, and increasing the endogenous, that is hepatic glucose glucagons. And one more mechanism of action is that reduces the oxidative stress and the inflammation. Coming to the DPP4 interaction, DPP4 the mechanism of action. So it reduces the endogenous, that is hepatic glucose glucagons. At the same time, it reduces the inflammation and the oxidative stress. At the same time, it increases the endothelial function, that improves the endothelial sensitivity, and the macrophage infiltration is reduced, and the calcium deposition is also reduced. And the last mechanism of action of DPP4 inhibitors is the insulin secretion is increased, and the incretin effect, the GIP is increased and the GLP-1 is increased. So put together, the SGLT2, they are acting on the kidney, they are acting on the pancreas, and they are acting on the heart, they are acting on the gut. That is the mechanism of action of the synergistic and the complementary mechanism of action of the SGLT2 inhibitors and the DPP4 inhibitors. So by acting on the kidney actually, so this particular the SGLT2 inhibitors, they act on the proximal convoluted tubules, where you find more than 95% of the SGLT2 receptors. So whereas SGLT1 receptors are present at the straight convoluted tubule. So the SGLT2 inhibitors, by increasing the urinary glucose excretion to a tune of 60 to 120 grams a day, that reduces the systolic blood pressure very significantly, and it reduces diastolic blood pressure, but it is not that significant when compared to the systolic blood pressure, and that improves the estimated glomerular filtration rate, and it reduces the albuminuria, it reduces body weight, just because it excretes on an average 80 to 100 grams of glucose per day. So the greatest advantage is also that reduces the DPP4 inhibitors, they reduce the serum uric acid, which is a beneficial effect in cases of hyperuricemia. See, hyperuricemia, type 2 diabetes mellitus, and hypothyroidism, these are the clinical triad. They are intermingled. Usually when you find a case of type 2 diabetes, you find hypothyroidism, and at the same time you find hyperuricemia. See, whether it is called gout or not, okay, whether it is symptomatic or not, but when it crosses the borderline of 7 milligrams per deciliter, the serum uric acid, it is called hyperuricemia. If it is associated with the symptoms, we call it gout. Whatever it may be, if not associated, we don't call it gout, but we call it hyperuricemia. So at the level of pancreas, the the hyperglycemia is reduced, and the serum uric acid is reduced, and the systolic blood pressure rate is reduced, and the risk of hypoglycemia is also very much reduced. And on the heart, the cardiovascular events are reduced, And as far as the DPP4 inhibitors are concerned, they are always weight neutral. Though they cannot decrease the weight, but they don't tend to increase the weight. Unlike other drugs like sulfonylureas or the pioglitazone. So this synergistic effect makes this a perfect combination in the management of type 2 diabetes mellitus, that is treat to target. And this slide shows the efficacy of modern diabetes treatments, the DPP4 inhibitors and the SGLT2 inhibitors, and the very important modality is the GLP-1 receptor agonists in white and Asian patients with diabetes. A systematic review and meta-analysis of randomized control trials. The inference is taken from the meta-analysis of the 64 randomized control trials. The glucose lowering efficacy of SGLT2 inhibitors and to a lesser extent the DPP4 inhibitors was greater in studies of predominantly Asian ethnicity compared with the studies of predominantly the white ethnicity. So the greatest advantage of SGLT2 inhibitors and the DPP4 inhibitors, it is very effective in Asians when compared to the Caucasians, that is the whites, because the SGLT2 inhibition and the DPP4 inhibition is highest, the maximum, when you see it in the Asian population. So when it is related to the GLP-1 receptor agonists, we don't find that the difference in the ethnicity. So the reductions of blood pressure, the blood sugar and the glycosylated hemoglobin are same in Asians and the Caucasians as far as GLP-1 receptor agonists are concerned, whereas the reductions in the blood sugar and the A1C are greater in Asians when compared to this particular the whites, as far as the SGLT2 inhibitors and the DPP4 inhibitors are concerned. So SGLT2 inhibitors in combination with other antidiabetics, the point to be taken is that it is compatible with all the drugs, starting from metformin, the sulfonylureas, the alpha glucosidase inhibitors, the thiazolidinediones, or the DPP4 inhibitors, or the GLP-1 receptor agonists, or with the insulin. The only thing is, whenever you are initiating SGLT2 inhibitor to the existing pre-existing medication, you have to be cautious if the patient is on insulin or sulfonylurea, because the initiation of SGLT2 inhibitors is going to cause a drastic change in lowering blood glucose levels as well as the HbA1c, so that you need to titrate the dose, down titrate the dose of sulfonylurea and down titrate the dose of insulin to prevent the hypoglycemia whenever you want to initiate SGLT2 inhibitors. The patient is not on sulfonylurea and insulin, there is no issue. So combination of SGLT2 inhibitors and the plus GLP-1 receptor agonists bar DPP4 inhibitors appears to be a promising therapy. And now we'll see the glycemic control with the SGLT2 inhibitors in combination with the DPP4 inhibitors. The on top, the first one you can see the empagliflozin, the linagliptin and the combination, and the second is T2Gliflozin and Sitagliptin and combination, and the Dapagliflozin and the Sitagliptin and the combination. See, this is nothing but it is based on the manufacturers. The empagliflozin and the linagliptin are the research molecules of Boehringer Ingelheim, and whereas the T2Gliflozin and the Sitagliptin are the products of Merck and MSD, which are sister concern. And this particular dapagliflozin and saxagliptin are the products of AstraZeneca. So when you take this, the HbA1c as parameter, the empagliflozin alone was able to reduce the A1c by 0.7%. And similarly, the A1c of linagliptin is also equally efficacious when compared to the empagliflozin. And when both, it is 0.7%. When both are combined, the EMPA and LINA, the reductions in the A1C is very significant. That is, it is reduced by 1.1%. And when we take 2-gliflozin alone, it is going to reduce 1% of HbA1c, whereas sitagliptin 1.1%, and combination reduces by 1.5% respectively. When you take the dapagliflozin itself reduces to a tune of 1.5%, and saxagliptin reduces by 0.9%, and the combination has resulted in reduction of only 1.2%, which clearly shows that there is no synergism between the dapagliflozin and the saxagliptin. The significant reduction in HbA1c with SGLT2 inhibitors combination therapy compared to monotherapy with gliptins. See, this is quite natural. When two drugs are combined or three drugs are combined, naturally the reductions in A1C are definitely higher than that of the monotherapy. And now coming to the effect of this particular SGLT2 inhibitors and the DP4 inhibitors, the combination on the blood pressure and the weight. The same thing, the empagliflozin, when it is related to body weight, it was able to reduce by 2.5 kilograms, whereas linagliptin very meager 0.7 kilos, and in combination it is around 2.6 kilograms of weight reduction. So when you take this particular etogliflozin, it is 2.7 reduction, and sitagliptin alone 0.7%, 0.7 kilograms, and in combination to a tune of 2.5 respectively. It is more or less similar to that of the empagliflozin and the linagliptin. And coming to the last one, the dapagliflozin was able to reduce by tune of 2.4 kilograms, and whereas the saxagliptin, there is no weight reduction, it is just weight neutral, and when put together it had reduced by 2.1 kilos. That shows this particular combination doesn't have the synergistic effect either in reducing the HbA1c or reducing the weight also. And coming to the systolic blood pressure, it is 3.5 with empagliflozin millimeters of mercury, and 0.3 millimeters of mercury with linagliptin, and put together it is 2.8 millimeters of mercury of systolic blood pressure. And the same with the etogliflozin is 3.9 millimeters of mercury, and the sitagliptin 0.7 millimeters of mercury, and put together it is 3.4 millimeters of mercury of systolic blood pressure respectively. And when you take this dapagliflozin, 3.5 millimeters of mercury, and the saxagliptin 0.3, and the combination was able to reduce by 1.9 millimeters of mercury. Significant reductions in the systolic blood pressure and the body weight with the SGLT2 inhibitors, the combination therapy compared to monotherapy of gliptins. And this slide, this is a very busy slide that shows the safety of the combination of SGLT2 inhibitors and the DPP4 inhibitors. So from all these studies, the 1, 2, 3, 4, the 7 studies, you can see the safety of this particular the combination of an SGLT2 inhibitor with a DPP4 inhibitor. Overall safety profile of combination is similar to those of the individual components, and the DPP4 inhibitors, they moderate the risk of genitourinary infections associated with SGLT2 inhibitors. This is a very important point. See, alone when you use SGLT2 inhibitors, you find some amount of the genitourinary tract infections or the urinary tract infections or the genital, the mycotic infections. But when it is combined with this particular the SGLT2 inhibitor is combined with the DPP4 inhibitors, you find a significant reduction in the incidence of the GUTIs, or the UTIs, or the genital mycotic infections. The reason is exactly not known till today, but the postulated theories are that the DPP4 inhibition is very significant in reducing the infections, either the bacterial infections or the fungal infections. The second proposed theory is that the DPP4 inhibitors, they lower the pH of that particular area, the genitalia, so that the infections, either the bacterial, the UTIs or the genitourinary tract infections or the genital mycotic infections are reduced. The meta-analysis of 5 randomized controlled trials directly comparing the frequency of genitourinary infections in the patients receiving a combination of DPP4 and SGLT2 combination therapy versus those receiving an SGLT2 only. The lower rates of GTIs were reported with the FDC as compared to SGLT2 monotherapy. And at this particular junction, I would like to mention that the latest studies done during this 2021 and 2022 have clearly said that the increased incidence of the urinary tract infections or the mycotic infections are not because of the SGLT2 inhibitors, it is because of the diabetes per se. Uncontrolled diabetes per se is the reason for this, the increased bacterial or the fungal infections. So you cannot blame the SGLT2 inhibitors, though the US FDA has received 19 cases of severe urosepsis and pyelonephritis from the patients who are on SGLT2 inhibitors. We still don't know whether this is because of the uncontrolled blood sugars or because of the SGLT2 inhibitors. So US FDA, after receiving the 19 case reports, did not conclude and did not say anything. And in this lecture, I just have to mention that there are 19 case reports reported to the US FDA, that in the 19 cases of that particular, the case reports had shown the Fournier's gangrene or the necrotizing fasciitis of the perineum. But still it is not known whether it is because of the SGLT2 inhibitors per se or because of the uncontrolled diabetes.
Sir, any charging network? Your phone on this.
So this slide shows the global and Indian approval status of SGLT2 inhibitors plus DPP4 inhibitors as fixed dose combinations. So the first one which was approved by the US FDA was Dapagliflozin and Linagliptin. The brand name is Glizambi. It was approved in 2015. The DCGI approved this particular combination in India in 2017, and it is commercially available in India from 2018. Whereas Dapagliflozin and Saxagliptin US FDA approval, they got it in the year 2017, DCGI approval 2019, available from 2020. The Atugliflozin and Sitagliptin, the US FDA has given approval in 2017, but it is not approved by DCGI, it is not available in our country. And the Remogliflozin, the Indian gliflozin with Vildagliptin, which doesn't have the US FDA approval, and DCGI said yes in the 2020, and it is commercially available in India from 2020. So whereas the combination of Dapagliflozin and Vildagliptin, it is not approved by US FDA because this is the generic versions. Soon after the Vildagliptin was off patent, and soon after the AstraZeneca people lost their case in the Supreme Court of India. So all our Indian pharmaceutical companies have started making this particular combinations. So they are obviously not approved by US FDA because Vildagliptin has no approval at all by US FDA. Though Vildagliptin is the mother gliptin, actually that was the first gliptin in the world by Novartis. It's a research molecule of Novartis. Though Novartis is the one company that has coined the term gliptins along with the World Health Organization. So even before Sitagliptin was introduced, but they did not have CVOTs, and by the time the US FDA asked to produce the CVOTs, by the time they submitted, entire US was flooded with Sitagliptin, the Merck by Merck. So they never wanted US FDA approval. They wanted to rule the rest of the country, barring the rest of the world, barring USA. So the DCGI said yes to DAPA and Vilda in the year 2022, and it is available from 2022. The same thing, the Dapagliflozin and the Sitagliptin, it is not approved because see, this combination is not from the same company. See, US FDA approves only the molecules from the same mother company actually. So DCGI said in 22, yes, like Dapa Vilda, now Dapa Sita, it is available from 2022. So the Dapagliflozin plus Sitagliptin, the new FDC in the management of type 2 diabetes mellitus. Let us see what Dapagliflozin says. Okay, it has got a proven cardiovascular benefit. It is backed up by declared TIMI 58, DAPA HF, and DAPA CKD trials. And the extended indication is the heart failure with reduced ejection fraction and the CKD. And now the latest data shows that the heart failure with preserved ejection fraction is also an indication for Dapagliflozin, and there is in between a term, heart failure with reduced ejection fraction, HREF and HPF. There is an entity called the heart failure with mildly reduced ejection fraction, that also needs Dapagliflozin, and now it is approved for all the three, the HREF and the HPF and the heart failure with mildly reduced ejection fraction. So the beneficial pleiotropic effects all the, not only dapagliflozin, all the gliflozins which are available in our country, like empagliflozin or the dapagliflozin or the canagliflozin, apart from their this thing, the main purpose is glucose lowering. They reduce the BP, they reduce the weight also. So the clinical benefits are other conditions. The non-alcoholic steatohepatitis, and prior to that non-alcoholic fatty liver disease, NAFLD and NASH, prediabetes, and heart failure with the preserved ejection fraction, the obesity, and the PCOS. See, the class of SGLT2 emerged. The first molecule was canagliflozin, followed by empagliflozin, followed by dapagliflozin, and followed by the A2gliflozin. But the three molecules available in India approved by USFDA are the canagliflozin and the EMPA and the DAPA. So they emerged as glucose lowering agents. So that was to the domain of an endocrinologist, or the primary care physician, or the diabetologist, or the physicians. And later on, based on the studies that have shown the tremendous efficacious results in reducing the 3-point MACE and the heart failure and the hospitalization for heart failure, then the cardiologist started claiming it is our molecule. And later on, seeing the DAPA CKD, which improves the kidney function by improving the estimated glomerular filtration rate, the nephrologist started saying it is our molecule. And after seeing the beneficial results in the NAFLD and NASH, the gastroenterologists now they are saying it is our molecule. But it is everybody's molecule, every clinician's molecule, every patient's molecule. So coming to sitagliptin, the convenient once daily regime, see, to mind you, except the vildagliptin 50 milligram BD, all gliptins are once daily only. And now even the Vilda has come out with 100 milligram SR preparation, sustained release preparation, which is shown to be very efficacious. The results are similar to that of the 50 milligram BD doses, which is approved by the national and the international bodies, and the low potential and convenient. See, coming back to sitagliptin, so convenient once daily, low potential for drug to drug interactions, safe and effective as monotherapy in combination with other OADs. But as monotherapy, we never use either the DPP4 inhibitors or the SGLT2 inhibitors as monotherapy, as long as the patient is intolerant to metformin. But if I want to tell you the facts, the first international body was the European Society of Cardiology, which has said in way back in 2019 that the patient is drug naive patient, that is type 2 de novo patient, whether at risk of developing atherosclerotic cardiovascular disease or has an established atherosclerotic cardiovascular disease, without metformin, you can use either the SGLT2 inhibitors or the GLP-1 receptor agonists, or if required, the combination of SGLT2 inhibitors and the GLP-1 receptor agonists. And later on, the EASD, the European Association for the Study of Diabetes, has joined its hands with the European Society of Cardiology and clearly said, came out with a joint consensus, that is ESC bar EASD consensus 2019 clearly says that you can start this particular SGLT2 inhibitors alone if the heart failure predominates And if the atherosclerotic cardiovascular predominates, the GLP-1 receptor agonist or combination of both. That was said in year 2019. So coming to this, the DPP4s, the low risk of hypoglycemia and no weight gain. They are CV neutral and the weight neutral also. See the Dapagliflozin, the summary of cardiovascular outcome trials. Coming to the first one, the declared TIMI 58. The patient population, type 2 diabetes, who had or were at risk of atherosclerotic cardiovascular disease, and the result is the 27% relative risk reduction of hospitalization due to heart failure. The DAPA-HF, the New York Heart Association class 2, 3, 4, heart failure and ejection fraction of around or less than 40. That is defined as the heart failure with reduced ejection fraction. So the result is the relative risk reduction by 26%, the composite of worsening heart failure or the cardiovascular death. Coming to the DAPA-CKD, the patient selection was the EGFR of 25 to 75 ml bar minute per 1.73 meter square of body surface area, and urine albumin to creatinine ratio with albumin measured in milligrams and creatinine measured in grams of 200 to 5000. The results were 39% of relative risk reduction sustained declined in the estimated glomerular filtration of at least 50%. The end stage renal disease or the end stage kidney disease or death from renal or cardiovascular causes. So this is the evidence based medicine what we have behind dapagliflozin. So the main features are the 5 marketed DPP4 inhibitors. You take the sitagliptin and the vildagliptin and the saxagliptin, linagliptin and the alogliptin. So all can be used, but when it is related to heart failure, you have to stop this particular saxagliptin, as the SEVA TIMI 53 study has clearly shown that this increases the risk of heart failure. So you have to be cautious with saxagliptin. So better discontinue it, and you have to be little bit cautious with even alogliptin also. Others apart from this, the sitagliptin, the vildagliptin, the linagliptin, they are almost cardiovascular neutral. The one major point to be remembered with vildagliptin is the VIVID study, the VIVIDDD. That VIVID study has shown that vildagliptin in the long run may increase the left ventricular volumes. In future, that may lead to heart failure. So you have to be cautious with saxagliptin and alogliptin and vildagliptin also. So now the pharmacokinetics and pharmacodynamics of vildagliptin versus sitagliptin. See, I don't find much difference between vildagliptin and sitagliptin, but today's topic being sitagliptin, I just have to say this because I use extensively in my practice the vildagliptin and the sitagliptin and the linagliptin, but never saxagliptin. The dosage of vildagliptin is 100 milligrams per day, either 50 milligram BID or I said 100 milligram SROD has come, okay, and sitagliptin 100 milligram OD. And the dosage change in renal dysfunction, no dose adjustment is required until an AGFR of 45 ml per minute, and if it is less than 45 ml per minute, you have to reduce from 100 milligram of vildagliptin to 50 milligram of vildagliptin. If it goes even below 30, you have to come down to 25. Better is to avoid this molecule. Also, the same thing holds good for sitagliptin. See, when it goes below 45, you have to reduce from 100 to 50 or 50 to 25. If it goes below 30, 25 milligram, and during dialysis they say it is 25 milligram once daily, but all are with insulin only. But I would like to say that it's better to avoid all the gliptins, all the DPP4 inhibitors when the kidney function is declining at a stage 4 or stage 5 during dialysis. The only one gliptin that you can rely on is the linagliptin. You start with 5 milligram, you stay with 5 milligram, whatever be the EGFR, whatever the stage of this thing, even during dialysis or during the transplant. And there is a special entity called the PTDM, that is called post transplant diabetes mellitus. After any transplant, not only kidney transplant, any transplant, let it be liver transplant or let it be lung transplant, whatever it may be. See, after the transplant, we give cyclosporin and the other drugs to avoid the rejection. So that leads to hyperglycemia, which may be very persistent, that cannot be put into any of the four categories what we have, the type 1, type 2, or the other specific types, or the GDM. So this is a complete different scenario where we call it new onset post transplant diabetes mellitus. And you can see all the parameters with regards to vildagliptin and sitagliptin. You all know this. I said the cardiovascular safety COOT is not available, whereas TECOS is there, which is CV neutral with sitagliptin. And sitagliptin in the treatment of type 2 diabetes, so significantly that reduces A1C by 0.74%. And the greatest initial HbA1c reduction with sitagliptin in the TECOS population was in Oriental Asians. And effects of sitagliptin as monotherapy and add-on to metformin, weight loss among the overweight and obese patients with type 2 diabetes, a systematic review and meta-analysis. So the conclusion is that the sitagliptin administration with or without metformin might reduce the body weight and body mass index if these drugs are taken for more than 6 months. But to the best of my knowledge, the evidence-based medicine says that all the gliptins are weight neutral. They never reduce the weight. The cardiovascular effects of sitagliptin you can see by the anti-inflammatory effect and the anti-oxidative stress and improving the nitric oxide bioavailability by decreasing the lipid accumulation, the anti-apoptotic action and the accelerating. These are all the effects on the heart. So that which make this particular sitagliptin a cardiovascular neutral product. So this is about TECA study, we know about it, okay. So this is also TECA's hospitalization from heart failure. You don't find any difference. The two graphs, the blue one is the placebo, the red is sitagliptin. See, almost they are merging together from the beginning till end, which says that it doesn't have any positive effect on the heart failure. Sitagliptin has got no positive effect on the heart failure when compared to placebo. I said it is always heart neutral. It is never pro heart failure or something else, except the DPP, the SGLT2 inhibitors. and this is TECOS. So no significant between group differences in rates of acute pancreatitis, pancreatic cancer, and the severe hypoglycemia. See, earlier it was a myth actually that DPP4 inhibitors or the SGLT2 inhibitors or the GLP1 receptors are associated with increased cases of acute pancreatitis and pancreatic cancer and severe hypoglycemia and all. It is a myth, no more a reality. See, this slide shows the what I have already told. Like 2019, the European Society of Cardiology heart failure guideline recommendations for DPP4 inhibitors. So 2019 new recommendations. So you can down below down you can see the green is the level of evidence or the class of recommendation. The level of evidence is always is ABCD. The level of recommendation is all the time 1, 2, 3, 4. So the first one, the diabetes treatment to reduce the heart risk, the which is in black, the green, the SGLT2 inhibitors, empagliflozin, canagliflozin, and dapagliflozin are recommended to lower the risk of hospitalization for the heart failure if the EGFR is more than 30 ml per minute per 1.73 meter square of the body surface area. And the second recommendation is the 2A actually. The first one is 1A. Second is metformin should be considered in patients with diabetes and heart failure if EGFR is same. The cutoff point for the SGLT2 inhibitors and the metformin is same. If it is below 30, you have to stop with the metformin or the SGLT2 inhibitors also. So the third one is again the GLP1 receptor agonists and DP4 inhibitors, sitagliptin and linagliptin, have a neutral effect on the risk of heart failure and may be considered. And insulin treatment in heart failure may be considered. That is also 2B. So then coming to the last, the class 3 recommendation, DP4 inhibitor saxagliptin in heart failure is not recommended. That I have already mentioned. The SAVAR TIMI53 study has clearly shown that it may induce heart failure. So likewise, the thiazolidine the pioglitazone and the rosiglitazone, we have only pioglitazone in our country, whereas the Western people, even in the United States of America, till today you find rosiglitazone and pioglitazone. In heart failure, they are not recommended because they are contraindicated in any volume overloaded state. So this is again TECAS and all. And the 10-year follow-up of sitagliptin treatment in patients with type 2 diabetes. On the right hand side, left hand side, you can see sitagliptin, and the right hand side, you can see the control. In the sitagliptin group, mean albumin excretion measured as urinary albumin to creatinine ratio was markedly decreased, but no changes in estimated glomerular filtration rate were seen throughout the study. So this is the same, the treatment with sitagliptin in the management of type 2 diabetes. This is HOMA B and the HOMA AR in sitagliptin group and the control group. And coming to the dapagliflozin is effective as add-on therapy to sitagliptin with or without metformin. A 24-week multi-center randomized double-blind placebo-controlled study, which clearly says that at week 24, dapagliflozin, this is the bar which demarcates between the two graphs. There is a vertical bar. That is week 24, dapagliflozin significantly reduced mean HbA1c levels versus placebo. So the efficacy of DAPA and the SITA, the FDC, EMPA-LINA versus LINA. The EMPA-LINA the HbA1c reduction is 1.1. If it is alone Lina, it is 0.7%. And the weight reduction, Empa Lina is 2.6 kilos, whereas only Lina 0.7 kilos. Coming to Dapa plus Saxa, 1.2% of A1C reduction and 2.1 kilos of weight reduction. Alone Saxa, 0.9% of A1C reduction and no reduction in the weight. Dapa Sita versus placebo. So the A1C reduction is 0.8% versus 0. The weight reduction being 2.1 kilos versus 0.3 kilos respectively. When it comes to Dapa Vilda, no clinical data available, and alone Vilda, no clinical data is available. Significant reductions in the A1C and the body weight with the SGLT2 inhibitors used in combination with the DP4 inhibitors, that is the combination FDC, compared to the monotherapy with gliptins. And the guidance for initiation of SGLT2 and the DP4 inhibition, the inhibitors, the FDC based on the glycemic control. So you can clearly see this particular this thing. So it fits into any category, like you start with metformin or you start with a combination of triple drug per se, metformin plus SGLT2 plus DPP4. Wherever it is used, it suits well, it goes well with any combination, any other drug used for the management of type 2 diabetes mellitus. So this is also the same, the cardiovascular risk. Cardiovascular risk is majorly reduced by the SGLT2 inhibitors, not by the DPP4 inhibitors. So these are the guidance for initiation of SGLT2 plus DP4 FDC based on promoting weight loss or preventing hypoglycemia. See, before, I think probably this is the last slide. Before going to the take home message, I would like to add some clinical points. The first clinical point I would like to say is, any pharmaceutical company will say where it is to be used, but I am much concerned about the fact that where it should not be used. They never highlight this. No pharma industry in the country, especially in our country, it is a totally different scenario. You take the European Union or the Canada or the USA and all, it's a crime if you don't say where it should not be used. See, the first take home message I would like to give is, start early in the disease course of type 2 diabetes mellitus, this particular SGLT2 inhibitor, because later on you want to introduce also, you may not be able to introduce because of the reduced estimated glomerular filtration rate. And the second important point is, you want to have the benefits on the blood sugar lowering, the cardiovascular benefits and the renal benefits and the liver benefits. You have to start this very early in the course of type 2 diabetes mellitus. See, the patient has duration of 40 years of diabetes. You start SGLT2, the patient will not have any of these benefits. Drug naive patient or the type 2 de novo patient, you start SGLT2 inhibitors, he is going to enjoy all the benefits. So the take-home message all the time is, start very early in the disease process of the type 2 diabetes mellitus, first thing. And whenever the patient has the dehydration, never initiate SGLT2 inhibitors. Whenever the EGFR is less than 30 ml per minute, never initiate SGLT2 inhibitor. Whenever the patient has got the active urinary tract infection or the genital mycotic infections never initiate this particular SGLT2 inhibitor. And whenever the patient says recurrent UTIs, the recurrent genital mycotic infections never initiate SGLT2 inhibitor. Suppose you start SGLT2 inhibitor and after some time the patient comes to you with a complaint of either UTI, bacterial or the mycotic infections. For the time being, you withdraw SGLT2 inhibitor and you treat the patient accordingly, like doing the basic workup like okay, culture sensitivity or the ultrasound abdomen, or until the patient is totally cured of this particular either UTI, and after some time you can again reinitiate. The patient again comes to you with the same complaint which has been subsided with your treatment, then that is not a cup of tea for that particular patient. So SGLT2 inhibitor should be withdrawn. And all the time, whenever you initiate this particular SGLT2 inhibitors, so ask the patient to get adequately hydrated, because if he is not hydrated properly, he will get into dehydration that leads to very deleterious hazardous effects. And always keep it in mind that these particular SGLT2s are not lipid friendly. They always tend to raise the LDLC. We all the time target LDLC, but this increases the LDLC. And all the time you have to keep an eye over the euglycemic decay, which is a side effect not only of this SGLT2 inhibitors. There are several conditions where you find this particular euglycemic decay, which is called EDKA. But of late, this has become a latest cause for this EDKA. See, the mechanism behind the euglycemic decay is whenever the patient is on SGLT2 inhibitors, the pathophysiology is such that the lowered insulin production from the beta cells, which in turn increases the secretion of glucagon. The low insulin and the high glucagon levels, this is called the counter regulatory hormone surge. You know, you are aware of the counter regulatory, or the regulatory hormone is insulin, and in contrary, the stress hormones or the counter regulatory hormones are the glucagon and the adrenaline, noradrenaline, cortisol, and thyroid and growth hormone. These six are called the stress hormones or the counter regulatory hormones. So when it is the insulin is lowered and the glucagon level is very much elevated, that leads to a shift in the drift from glucose metabolism to fat metabolism, which potentiates the ketogenesis. Thereby, it produces the ketone bodies. Though the blood sugars are normal, this is called euglycemic decay. The difference between decay and euglycemic decay is it is not that abnormal. The blood sugar is not 300, 400 like in DKA, but it rarely occurs in type 2 diabetes. Actually, DKA relatively when compared with the type 1, type 2, we see it, but not that frequently. But EDKA is commonly seen with the uses of this SGLT2 inhibitors, and the management is same. You have to first monitor the adequate hydration. Dehydration must be addressed properly. and insulin plus potassium. Electrolyte balance must be maintained. So isotonic NS. So if the patient is in sepsis, use antibiotics. See, the treatment remains same between EDKA and the DKA. So these are all the points to be considered when you prescribe an SGLT2 to the particular patient. You should ask the patient, elicit the history of recurrent UTIs or recurrent genital mycotic infections, or the patient is dehydrated, you don't put him on that. So the other conditions what I have said. So this is out of my experience I am telling you, because I have already told you the pharmaceutical companies don't be just biased what the pharmaceutical companies say. They all the time ask you to initiate. You must be thoroughly knowing when to initiate, when not to initiate. It is your responsibility. You can never say that, okay, pharma people have said that it can be initiated. The ultimate beneficiary or the ultimate loser will be the patient. With that, the take home message, the SGLT2 inhibitors and the DP4 inhibitors, they have the complementary mechanism of action, which is called the synergistic effect. This combination may be a pertinent partner to metformin in providing meaningful glycemia control without increasing the risk of hypoglycemia, and in improving the metabolic profiles of the patient. As far as hypoglycemia, I have already told that if the patient is already on sulfonylureas and insulin, when you are initiating this particular combination, or even the DAPA alone or the EMPA alone, you should reduce the dose of sulfonylurea, or they reduce the dose of insulin to avoid hypoglycemias, or else the patient will inevitably will land up in hypoglycemias. The Dapagliflozin and the Sitagliptin FDC has potential for improving adherence along with the glycemic control and the cardiovascular benefits. See, all the time you have to calculate the risk benefit ratio. So in this particular case, dapagliflozin, especially the benefits are more, the risk, there is no drug that has no risk. Likewise, dapagliflozin is no exception for that actually. It has got minor side effects, like what I said, the euglycemic DKA, or it may precipitate the genitourinary tract infections or the genital mycotic this thing, that may reduce that may increase the LDLC. So these are all the points to be kept in mind before you prescribe any dapagliflozin. So with this, I thank my fellow doctors for patient listening, and thanks to ReadyLab people for giving me this opportunity to be the speaker of this evening. And I am glad to take up any doubts, any queries, any questions regarding this particular molecule or the combination. Please go ahead. Pause.
We can start SGLT2 inhibitor.
Okay.
The patient has an inhibition to start insulin. So my question is,
Uh-huh.
at what level of HbA1c we can safely start 9, 8, and how long we should see that patient HbA1c is come down for 3 months. And how long does it take? So is it a real substitute for the insulin injection?
Sir, you mean to ask whether dapagliflozin is a substitute for insulin in the subset of patients where they have some insulin phobia?
That's the reason. Yeah.
Okay, so it's a wonderful question actually. According to the American Diabetes Association or the American College of Endocrinology or the AAs, that is American Association for the Clinical Endocrinologists, the cutoff point when you are supposed to initiate insulin, that is mandatory, is around or more than 9%. You have to initiate insulin either by stopping the pre-existing drugs, by going for a basal bolus regime, or you can choose any choice, like starting from basal insulin to basal plus to biphasic premixed, whether it is human or the analogs, along with the pre-existing drugs. When it is related to dapagliflozin, the A1C is not at all a criteria. When you have an A1C of 7%, when you have an A1C of 7.5%, you can happily start dapagliflozin to have the benefits of dapagliflozin. Per se, insulin doesn't give you any benefits, cardiovascular benefits, which is proved in the origin trial. All the time we were under the myth that insulin is going to do miracles and wonders. But when insulin is not indicated, it's not going to give the protection to the heart. But when there is some end organ damage, insulin becomes mandatory to prevent the further complications or the worsening of the existing complication.
My another question is, Krishna,
Uh-huh.
like suppose lipid profile is normal, everything is normal,
Okay.
and HbA1c is around 8 or 9.
Ah.
9, say 9, right? But main question is like in India, especially there's a injection phobia is definitely there with all of them.
Yeah, naturally.
Whether it's in a lower class, middle class, or high
Yes, absolutely, Rajdeep.
right? So can we take a trial at HbA1c of 9 with SGLT2 individuals? That is my main question.
That's what I am saying. When dapagliflozin is very much okay at the level of 7.5%, you can happily do it at the 8 or 8.5 or 9 also.
Okay, correct.
Only when the patient says no to insulin very bluntly and repeated counseling, when the A1C is around or more than 9%. And my advice, what I do in my day-to-day practice is, with a red pen I write on the prescription, insulin is very much required, insulin is mandatory as the A1C is around 10%. But the patient bluntly refused. He just wanted only orals. So most of the times, the combinations will work out, and ultimately the results will be very fruitful. Rasdeep, after 3 months or 6 months, slowly the A1C comes down. So that is the reason what I said in the beginning is, irrespective of the A1C, if it is even 6.5 also you can initiate dapagliflozin. 7 you can initiate, 7.5 you can initiate, 8 you can initiate without any hesitation, because the patient, 9 also we can initiate, provided the patient says absolutely no insulin. And to be pardon?
If the patient is in a catabolic state, that is a different ballgame.
See, when the patient is in catabolic state, you have to initiate insulin being an anabolic hormone. That goes without saying. There are compelling indications, like when the patient is in DKA, when the patient is in end organ damage, when the patient is hospitalized with some sepsis, whatever it may be, you have to use insulin. You can never in that particular conditions, even the patient is on the dapagliflozin or the empagliflozin, you have to withdraw and then only treat the patient only with this particular insulin. You want to have the benefits of the SGLT2 inhibitors per se, the DAPA and the EMPA. You have to initiate it very early in the course. That's what I stressed, Rajdeep. So a position, a stage comes when the patient comes to you with an EGFR of 25 ml per minute, you cannot initiate. There won't be any sort of benefit. That's a contraindication. Why I am telling you to put it on the paper? To save your skin from the consumer forum. The patient, on one hand, he says, I am afraid of insulin. And second, he says, I want oral drugs. And by any chance, some other doctor says, how doctor has prescribed orals when insulin is to be initiated, he'll file a case against the doctor who has initiated Dapagliflozin. So, best thing I do from the last 3 decades is, I put it very bluntly on the prescription paper that the patient badly requires insulin, but in spite of my repeated counselings, he has not listened to accept insulin, and hence I am forced to start orals, and I will take the signature of the patient as well as the attendants like wife or son. So the paper will be with them. When they want to file a case, we are very safe. Not with a bad intention, I am telling you, with a good intention, I am telling you. Nowadays, patients have become very intelligent. First, you have to save your skin, then you can save the patient's skin, Rajdeep.
Yeah, that is clear.
Is your doubt clarified?
Yeah, it's absolutely clear.
Absolutely clear? Okay, good.
Thank you, Krishna.
It's my pleasure to have you, Rajdeep.
It's my pleasure, Krishna.
Rajdeep is my classmate in medicine, my good old friend from last 40 years. Ever since 1982.
You become a mentor now.
Not at all. Thank you, thank you. Any doubts, please?
Sure.
You can.
You on the WhatsApp always.
Yeah. The other participants, they want to raise their voice. They can straight away ask me the questions, please. Beg the pardon of the participants. For the sake of time, some not very important slides I had just skipped on. The trial part and all, which is not required actually for a clinician. It is important for me, but keeping the time in view, I have prepared the lengthy slides to have the latest evidence-based medicine regarding the SGLT2 and the DPP4 inhibitors.
Future, let's have some small discussion of the SGLT1 also. So the futuristic question.
SGLT1, yes, the molecule has already come.
Okay.
This is called Sitagliflozin from Lexicon. Actually, Sanofi and Lexicon were partners actually, but after that, Sanofi and Lexicon, they got bifurcated. Now this particular Sitagliflozin is the only one kind of its gliflozin which acts on the both SGLT1 receptors and SGLT2 receptors also. The brand name is Infipia, which is not available in India, very much available in the United States of America. That's a wonderful molecule, Rajdeep, because of the SGLT1 inhibition and the SGLT2 inhibition, the results are much more better than these particular molecules.
I know that. That's why I asked this question.
Yeah.
How about the genetic complications with this?
The similar, more or less similar. See, per se, I have told you, the latest studies, they conclude that the side effects, the genitourinary mycotic infections, the bacterial or the fungal, are not because of the SGLT2 per se. They are because of the uncontrolled diabetes. The studies have rolled out very recently. Couple of months ago, the results have come. The multiple studies done in the US only, done in the US under the supervision of the US FDA.
But 88 2023 doesn't mention this what you're talking about.
the, the results rolled out after the standards of the ADA 2023 rolled out. See, every year, Rajdeep, in the month of December 15th, suppose 2023 guidelines will roll out on the net in the month of December 15th, 2022 only. So that becomes official when the first issue of diabetes care comes to us. That is January issue of diabetes care, which is the official journal of there are two official journals. One is diabetes purely for research purpose, and diabetes care is for clinicians. So the first volume of diabetes care, that is January, doesn't have any articles except the guidelines, the recommendations, the standards of medical care in diabetes 2023. That's all.
Yeah, I read that.
Yeah. Even before that, 1 month prior to that, I take a printout of the guidelines. I'll see what is the difference between 22 and 23. Hardly nothing. Only thing is they have taken off this C peptide as the one of the investigation portfolio for diagnosing type 1 diabetes, and they have taken out even the LADA also. They have taken out all the GAD antibodies and all. Simply they say fasting plasma glucose or random blood glucose or the casual plasma glucose and HbA1c.
Yeah, there's hardly any representativity to it.
That's what I very little changes. Very little changes. What they do is they take away the term microalbuminuria, they replace with UACR, urine albumin creatinine ratio. Nothing differs. Below 30 normal, 30 to 300 microalbuminuria, more than 300 macroalbuminuria. But they call it UACR. There is no more term called microalbumin. Microalbumin is a history. Now the running term is UACR.
Acronyms are there. I read that. Something has to be there, no?
Something has to be there, right? Okay. Old wine in the new bottle.
Excellent, Krishna. Excellent.
Thank you so much, Rajdeep. Love you so much.
My pleasure talking to you, Krishna.
All the time. It's my pleasure to be with you, Rajdeep.
Yeah, great.
I don't know when we meet in person.
Here we can talk only in the official language. Not in the SLC language.
That's wonderful. Good, Rajdeep. So, shall we wind up the technical team, please?
Sure, sir. Thank you, sir. Thank you for getting us so much.